Differential diagnosis of tetanus. The main presentation of tetanus is convulsions. Therefore, differential diagnosis of tetanus is other causes of convulsions, like strychnine poisoning. In strychnine poisoning, no wounds present in the patient. And tetanus, which is the earliest manifestation of tetanus, is very late in strychnine poisoning. And in all differential diagnosis of tetanus, the muscles are relaxed in between the attacks of convulsion, while in tetanus, the muscles are spastic and there is tonic spasm in between the attacks of convulsions. The second cause for convulsion is tetany, which is due to hypocalcemia. Therefore, calcium level in the blood is diagnostic for tetany. Plus, the earliest manifestation of tetany is spasm in the hand and the foot, which is called carbopedal spasm. Trismus, due to any local cause, like septic tooth, abscess in the teeth, etc. In this case, there is no spasm of other muscles in the body. There is only spasm in masseter muscle. Meningitis. Meningitis is a cause for convulsion. Characterized, the earliest sign is head retraction and neck rigidity. And the CSF specimen is diagnostic. The CSF is turbid and containing the organism meningococci and containing leukocytes. Rabies. Rabies, there is history of dog bite, and rabies is characterized by hydrophobia. Convulsions occur on seeing or drinking water. And in rabies, the muscles affected mainly muscles of deglutitions and respiratory muscles. And in rabies, the muscles are relaxed in between the attacks of convulsions. What is prognosis and complications of tetanus? The prognosis of tetanus is very good in immunized patient if there is long incubation period, because long incubation period allows the body to produce antitoxins. And also prognosis is very good if the wound away from the head and neck, away from CNS. Why? In this case, the incubation period is long, which allows the body to produce antitoxins. And also prognosis is good in young adults. The mortality rate is directly related and proportional to the severity of symptoms. In acute tetanus, the mortality rate is about 60% at least, within few days. This occurs within few days. Why? Usually due to respiratory complication, asphyxia and pneumonia, or exhaustion, hyperpyrexia, and heart failure. What is investigations for tetanus? In tetanus and gas gangrene, which are gram-positive bacilli, detection of the gram-positive bacilli in a smear from the wound or from the discharge is characteristic. Therefore, the diagnosis of tetanus and gas gangrene depends on the clinical manifestation and the detection of the gram-positive bacilli in the wound. In tetanus, blood picture show leukocytosis, and very important, there is leukocytosis in tetanus because in gas gangrene there is leukopenia. What is the treatment of tetanus? Treatment of tetanus is mainly prophylactic. Treatment of tetanus is mainly prophylactic. The treatment of tetanus is mainly prophylactic. First of all, tetanus is a preventable disease, mainly by proper management of the wound. First of all, improve vascularity of the wound by correction of hemorrhage, shock, and relief of any constricting agent like tourniquet, tight cast, and proper debridement of the wound. Proper debridement of the wound, excision of all dead muscles. How to know dead muscles? Dead muscles can be detected by doesn't bleed on cutting and doesn't contract on benching, and excision of dead, bruised, devitalized tissue, remove of any foreign body and blood clots, and in any contaminated wound. Any contaminated wound, never close the contaminated wound. The wound is left open with free drainage. And if the wound is left open with good aeration and the presence of oxygen in this area, this will inhibit the Clostridium tetani. Never close the deep fascia, because if you close the deep fascia, this provides the anaerobic medium for Clostridium tetani. And avoid closure by tight sutures, and avoid tight bandages, and frequent wash with H2O2 to allow oxygen to invade all parts of the wound with inhibition of the Clostridium tetani. Daily examination of the wound to detect any complication. In addition to proper management of the wound, prophylactic antibiotic for any contaminated wound. The third point, which is the cornerstone in prophylaxis against tetanus, is immunization. Immunization, there are two types of immunization: active immunization and passive immunization. The active immunization in children, it is routine before the age of 6 years. All children receive DBT, which is against diphtheria, pertussis, and tetanus toxoid. DBT, diphtheria, pertussis, tetanus toxoid. And after vaccination and active immunization, a booster dose of tetanus toxoid every 10 years. This is routine immunization in all children. In adults, active immunization by 3 doses of tetanus toxoid. Each dose is half milliliter, intramuscular every 4 weeks. In adult, this immunization is routine for all soldiers and all pregnant women and at the time of any injury. This provides perfect immunization for 10 years. This is active immunization. Passive immunization. Passive immunization is given for unimmunized patient with contaminated wound. At the time of injury in this unimmunized patient, we give 250 to 500 units of tetanus immunoglobulin, which is given at the time of the trauma. In the past, there was anti-tetanic serum, which has no role in modern surgery and should be avoided because it carries a risk of hypersensitivity and anaphylaxis. Therefore, if anti-tetanic serum is given, sensitivity test for this drug should be taken. What is the prophylaxis of any injured patient during the trauma? First of all, the condition depends upon previous history of immunization and the type of wound. First of all, if the patient was fully actively immunized by 3 previous doses within the previous 10 years, the patient has good immunity and a booster dose only of tetanus toxoid is enough. If the patient is not fully immunized or not immunized at all, what is the immunity and the immunization for this patient? This depends upon the type of the wound. If clean minor wound without risk of tetanus, it is enough to give active immunization by the routine 3 doses, half milliliter intramuscular every 4 weeks. But if the wound is contaminated with high risk of tetanus and the patient is not immunized before, we should take care in this patient. We use all my weapons against this disease to prophylaxis against tetanus. First of all, immediately in this contaminated wound, start active immunization plus passive immunization by tetanus immunoglobulin. But we should notice that tetanus toxoid is given in one syringe, in one site, and tetanus immunoglobulin is given in another syringe, in another site to be effective. If you mix tetanus toxoid, which is active immunization, with the tetanus immunoglobulin, no effect of both, no effect of tetanus toxoid and no effect of immunoglobulin, plus antibiotics. Therefore, in contaminated wound with high risk of tetanus, active immunization immediately with passive immunization, tetanus immunoglobulin plus antibiotic. After prophylactic treatment, what is the curative treatment in established cases? Established case of tetanus, we should neutralize the toxins immediately by massive dose of tetanus immunoglobulin. We give 3,000 to 6,000 unit intramuscular, and this dose may be repeated in the following days. Plus, After we start tetanus immunoglobulin, we should care of the wound. Proper management of the wound as before, and as usual, contaminated wound should be left open with proper drainage. How to control convulsions? Mild convulsions can be controlled by Valium or barbiturates. But severe convulsions, we need muscle relaxants with mechanical ventilator through a tracheostomy. Why through tracheostomy? Why not through endotracheal tube? Because mechanical ventilator in this patient usually needed for many weeks, long duration, and we all know the time allowed for endotracheal tube is 10 days. More than 10 days, this leads to laryngeal fibrosis and laryngeal stenosis. Therefore, for long duration with mechanical ventilator, we should perform tracheostomy. Therefore, in severe cases, convulsion is controlled by muscle relaxant with mechanical ventilator and tracheostomy. Nursing and caring of the patient. Isolate the patient in quiet dark room, away from any stimulus which may precipitate attack of convulsion. Feeding through oral tube. What about excretion? Excretion, we should castrize the patient, full castor, and repeated enema, plus oxygen inhalation. We should kill the organism, kill Clostridium tetani by massive dose of penicillin G, about 10 to 40 million units daily. This is tetanus. Thank you for good listening and good luck.